Excited about what we're going to see today. Very excited about the upside of this. Turn it over to Aenor. Thank you very much for joining us today and enjoy yourself.
Wow, this is an impressive crowd. How many people are here are in a startup or have started a technology company? Wow, all right. And how many are in funding, investing in these companies? Great, wonderful. And how many are in academia or in healthcare delivery? Right, a lot of people. So this is a very sophisticated crowd. This is just a high-level speed through where are we going, what is it that I think it would be really helpful for us. So forgive me if it's just too simple for you, but I always think that we need to look at the overview, at the 30,000-foot view sometimes when we're really in something and moving really fast. So I'm with the Center for Digital Health Innovation at UCSF. We'll talk a little bit about that in a minute. I'm actually an orthopedic surgeon, but I've been in device and digital health innovation for quite some time. So the overview is really overview of digital health. Where are we now? What should we be doing next, and what would be needed to get there? A little bit about Frontlines Innovations, why we think that's important, and then a plea, once again, to partner, because I think that's how we're going to get to effective healthcare solutions. So as you know, people are trying to define what is digital health from all different directions, and we know it's hardware, software, and with the cloud now, we know it's also nowhere. There are endless spectrums. You can look at tangible to intangible, sensors and devices, to the ones and zeros that try to make them meaningful. And then sizes range from nanoparticles all the way to infinity. There are lots of people who are early adopters, and anyone recognize this man? This is Dr. Michael Blum. He's the director of our Center for Innovation. He's also our CMIO at the medical center. I hope he's not in the room. Anyway, there are early adopters, geeky people, but way beyond that, this has spread out into the consumer world in a very broad way, across generations, across all kinds of sectors, and also still very involved in the medical arena and providing care, not just quantified self. So from the wearable medical devices to also smart implantable devices. So the components are incredibly varied, stretching all the way from databases and big data and computational health sciences through the hardware, the sensors, and all the software in between. So it's a very, very broad field. It covers a range of wellness, health, for the personal, for the population, and it serves consumers, patients, communities, government, payers, etc., many stakeholders. So now we call it hardware, software, nowhere, and everywhere. So that's digital health, if that helped clarify that. It's still very exciting. I think the edges are still way out of sight. We feel like there's limitless potential still. The abilities to expand in the use of digital health can come in terms of layering the data and learning about new associations and how to await associations that we didn't know about before. So moving from starting with observational to predictive and hopefully eventually prescriptive analytics, we have a long way to go, but by layering these data and looking for unique associations, including clinical data, physiologic, the patient-reported outcomes, clinical research data. Mind you, these are things that never intersected before, but with technology we could possibly layer these together. Data in the extended care setting, emergency settings, home medical devices, all the way down to the quantified self, and now consumer analytics. And many of you are aware of some of the early studies looking at cell phone usage and depression and finding strong correlations. Not the number of calls made associated with severity of depression, but actually the number of people called shrinking down from 10 to 2. So those are things that are inexpensive, already being collected, and if we can do the right kinds of associations, we can find new ways of predicting when someone might be getting into trouble and do more of a maintenance of health and wellness than episodic crisis care. So also you can tell it's exciting because this is a little bit old, but it's only gotten bigger. The investments in digital health and the funding in that arena has continued to grow. And luckily we're in the area that we live in. If you look at where a lot of the activity is happening, these are a couple years old, and I really thank my partners in Rock Health for this. We work very closely with the university and with Rock Health, and I think Nate's in the room today, one of the co-founders. We also work on building curriculum together and partnering in building effective healthcare solutions. Even though it's all exciting and still growing, things are starting to get a little more serious. We're starting to mature as a field, and here's an indication of that. And many people dreaded this happening, but I actually feel like it's a good thing. I think it's helpful. If we think that these things we're building are serious and are going to seriously impact health and wellness, then that means that they should be evaluated for safety. They should have some regulatory agency over them, particularly if there's a risk associated, if there's an intervention that's being directed based on data collected or an algorithmically driven protocol. What we need is better processes for this. So as you can imagine, most of the people in this room are on the cutting edge and the front edge of the wave of all this and the experts in the field. So you can imagine the people at the FDA, how steep the learning curve is for them right now. So the processes aren't clear, the criteria aren't clear, but we needed it to get started. And for one reason, I think investors were holding back a little bit, anticipating that this was coming and not knowing what the rules were going to be and how much it was going to cost. So we've grown up a little bit, we've gotten a little more serious, and that's an example. So what else is next? What will move us from promise, all the promise in digital health, to actually the power of digital health or the empowering of digital health, particularly for consumers? We actually thought of this as maybe the fourth modality with device therapeutics diagnostics, but in reality, digital health has the promise to be the great communicator and to really deliver on the triple aims at making better care available to more people at lower costs. Again, that's a promise, as is precision medicine, which you've heard a lot about. Being able to take data that we have on a specific patient, get it all the way into the clinical care loop at the front lines where the patient and provider are doing ideally shared decision making, and look at that data against a population-based data set, but making it very personalized to that patient, customizing the therapeutic to that patient. So what is needed to deliver on the promise? That takes us to need. The need is to contextualize the data to make it actionable. And there are several things that we need to do to actually get to this place where we're contextualizing data and making it actionable. We need to ask some really hard questions. Do we need more data? Do we need the right data? And how are we going to understand what is the right data? First of all, we need to over-collect, do a lot of those associations that we talked about, deliver on the analytics and the algorithmic development to understand what is right data. But it's something to think about as you're looking at what is the next thing we're going to be building or what are we building right now. Try to keep in mind some of the concepts of what it's going to take to get from the promise to the power. So does it measure what you say it measures? And is it effective? So that tells us we have a very big need for evaluation. And there's been a lot of excitement and a lot of fast building in this space, but it still remains that we are under-evaluating and under-demonstrating the effectiveness. And when I say effectiveness, I mean, of course, health outcomes, but I also mean financial or cost effectiveness. So two categories of effectiveness. We need to do a lot more in that area. And really, what does it mean? And understanding and contextualizing it can only happen with interoperability. So I'll speak to those two things in a little bit more detail as to what I think is needed. There are clear needs in two categories, and this is now coming from many voices. Interoperability and evaluation is what I'll focus on. Obviously, a couple other things are important too, one being sustainability and accessibility. So what is interoperability? This is HIMSS. How many are going to HIMSS next week? Yeah, let's meet up. And they came up with this fantastic breakdown of foundational, structural, semantic interoperability. But I think this is really the simplest. And these are things I've learned from Dennis Coleman, that it's, just keep it simple and get to the nuts and bolts of it. So the ability to exchange and make use of the information. It's pretty fundamental. And we're not doing a good job of this right now. Even in the clinical care system. Within the clinical care system, all of these things, inpatient, outpatient, administrative systems, ancillary systems, all of these things you would assume do interconnect. Even on a campus like ours, where we now have Epic inpatient and outpatient, we still have a very hard time getting data that the patient fills out in their history. They sit down in the clinic still with a paper form. And if they see an endocrinologist and the endocrinologist says you need to see the orthopedic surgeon, when they go to that clinic, they're going to get another paper form. And they're going to fill that out and they're going to say, well, honestly, the number of childhood fractures I had really hasn't changed from here to here, so why am I entering this again? And it goes in now in kind of a scanned document, finally getting it into Epic, but it's not going into any structured format or being routed to any place that might layer in and give us a better sense of what are that patient's risk factors for that condition. So these are things we need to work on. Also, patient-reported outcomes and clinical research data doesn't go in there anywhere. And between these lines, they're not really fully connected. So inside the clinical care system, where you think we'd ideally have it interoperable, we're still struggling. Then there's all the data being collected outside the clinical care record. So outside the clinical care record, that includes things that you can assume and imagine, the consumer-facing, the wearables, the records of things such as the medical devices, such as the glucometers that were mentioned. Very hard to get that data into the clinical care loop. I'll talk about that in a minute. And records from other care centers, the ambulance records. Your ambulance driver picks you up, you're in a life-threatening situation where your vital signs are fluctuating greatly, and what happens minute to minute needs to be tracked and needs to be reacted to. That patient then arrives at the ER, the ambulance driver hands over these sheets of triplicate carbon smeared papers, and then they pull out this long paper 12-lead EKG strip, roll it up and tape it on the back of the chart, and then hand that off. And all that information is really important. It was the last few hours of lots of variability that could really affect what decisions are made next. And that's how the data is transferred. So we have a lot of work to do, and I mentioned some of these other things already. One thing I want to point out is just imaging. The data from imaging, as far as integrating in a meaningful way into the clinical care loop, we have images, and then we have text documents, but they're not in structured fields. So to understand a patient who had a chest x-ray but showed a vertebral compression fracture, that sits in there like a few words. And that's not a structured term that ever really gets to someone who could act on it, but if we knew they had that, we could intervene with skeletal health work, prevent the next fracture, because they're 10 times greater risk, since they've had that, for having another fracture. So those pieces of data, we still don't have a great flow of getting to meaningful use. And then the outsourced data, including the genomic data. So interoperability is happening on some levels. Of course, you've heard of the HIEs, and this is a little confusing because there's health information exchange and now health insurance exchanges, just for fun. It's way behind in the expectations on the promise of that. There are now happening people doing their own sandboxes of HIEs. The intent was everybody play together well, but that hasn't happened. So Epic's building their own or has built their own, so has some of the other legacy systems. So it's not universal. We're still hoping very much that we can get more of that happening. On the consumer level, people are saying, we're tired of all this, we want to be able to have our own information, and as a cancer patient myself, it was incredibly difficult to gather my records, my images, and run around from expert to expert and try to gather those, move them around. The truth is, it would be great if we could have, we're the patient, can we have the information about ourselves? Even if we can't fully contextualize it, we could at least deliver it to the next person who can help us contextualize it. So people are building these systems. I think many people are aware of cloud-based systems that are not just image, but clinical information and data information collectors, and can be, depending on who's paying for it, deposited to the next provider. There are other systems that are happening around aggregation interoperability in the outside the clinical care loop. So some people are aware of the dashboards. Ginger.io, I think the most common, where you're aggregating data from different parts of your life, including consumer analytics, your wearables, and some of your apps. And TicTrac is a French-based company doing similar things. Baladic is in this area and doing a really nice job of this as well. And there are some others that are being built. And then the other piece of this, where we see interoperability really being pushed forward, is in the data analytics companies, Lumiata being one of them, where they're doing much advanced work on aggregation and analytics, and also risk stratification to then contextualize and make it meaningful and actionable. But the problem they're having is access to these databases. So if we think it's so important, why are there still so many big pieces missing to interoperability? Well, the one thing for sure is proprietary formats. So as you're building, yes, it's important to commercialize and have a sustainable business model, but is there any way you could imagine sharing or creating interoperability between your product and another? It will be a good business model for you in the end, because most things as a standalone aren't going to be a part of the overall effective healthcare solution. So think about it as you're building proprietary formats. It's very expensive to build these interoperability systems. They're complex, they require cooperation, and there are no clear aligned incentives at this time. We think it should look like this: stuff collected outside the clinical care record or outside the clinical care loop, with a bridge between and inside the clinical care loop, and they flow back and forth. But much like a cell, and sorry for the science geekiness of me, but There are many things that come to a cell wall in different formats. They need different receptors. They actually need to be processed in different ways as they come through the cell wall. And in the intracellular milieu, a ton of things happen to them before they ever get to a place in the cell where something actionable can happen. Either DNA, RNA, or amino acids and proteins get built. So very similar to this whole process we're talking about. Format's got to be changed, you've got to convert, you've got to analyze, you've got to create algorithms. So that data, once it goes into the EMR, can go directly to somewhere it needs to be to relate to something else in a format that's usable. So that there's a function that happens at the end of it. So this is actually what the cellular pathways look like. It's probably going to be much what our interoperability platforms look like ultimately. We've sketched it out like this in our simplistic, remember I'm an orthopedic person, so we like pictures and simplicity, but we simply have drawn it out this way with some of the key components, but you can see even that isn't as simple as we imagine it, or Paul Saunier has that wonderful video about digital health, and the second one, this whole imagination of how you wear something, you're walking around and your doctor's sitting in their office waiting for your data. What was your blood pressure when you went to the bathroom? I can't wait to find out. So it's actually not able to be done that way, and it's also not going to be useful that way. So again, sorting out right data, but how are we going to transfer it across in a meaningful way? So we do need to interface and integrate before we can ever imagine precision medicine becoming a reality for many people rather than in an ad hoc basis. The other piece that's really important is evaluation. So it's really time for everyone, not just us science or healthcare geeks, to say, does this work? It's really important. The academic medical center innovators have been asking for a long time. We thrive on scientific rigor. It somehow feeds us in a weird way. But it also is important to us because we don't want to be spending time or money or offering patients or telling them to do something that's not going to work. So we really care about whether these things work. I know you care because ultimately, if it doesn't work, it's a bad business model. So it all connects together. We need to ask if these things work. And now, of course, not just the geeks, but the stakeholders are asking. So the consumers are asking, the investors are asking, and the payers are asking. Do these things work? We have some information. So will it improve health and healthcare, digital health? Some proof. We do see that there are increases in patient satisfaction with the Press-Ganey scores and patient engagement with tools that give them more information or allow them more empowerment in their decision making. And those things actually do translate in an evidence-based way to better outcomes and even decreased readmission rates in some studies. So we know that's important. It's plus minus for providers right now. Some of us are still really feeling the pain of the EHR. We've become data entry clerks with very clean hands. But it's still very painful to do all the data entry and take time away from the visit or do it for hours in the evening. So it's plus minus, but we love having the data in front of us when it is there. And then for payers, there's been a lot of positive response about the digital health evaluation community. You see many of them buying up suites of things to offer as services to their clients. There's still the hope it'll actually lead to better health, which for them is a business model as well. That hasn't been proven yet. The promise is highly distributed healthcare, increased access that can be right-sized and specific to more people, lower cost, precision medicine, shared decision making. All of this in not just clinical care, but in research and development. Those are all big pieces that are still part of the promise. So in looking at does it work, there's actually been a lot more science on whether prayer works than whether digital health works. So we have a little bit of catching up to do. And not to discount prayer, but we could do better in our science around digital health evaluation. So we think we're leading the way from the front lines of healthcare, but we actually don't think that's good enough. We do want to disperse information as we get it on how to do digital health evaluation. The problem is it's not a succinct and well-defined field. So evaluation in digital health technology is very different than doing the large randomized clinical trials for therapeutics and diagnostics, etc. We need a lot of things different about it. It needs to move faster. There need to be breakdowns in where the evaluation is at what point in the arc of development. There's some resources for those of you who want to look into this and start applying it and implementing it in your development process. We have the CTSI at UCSF. Our behavioral medicine group has done a lot of advanced research in digital health, and the NIH is supporting a lot of that. and our Center for Digital Health Innovation. But there's some other great resources. Look at the Center for Technology and Aging. It's based in Oakland. They have a website, and they have an ROI, return on investment, on mobile health interventions, particularly in that population. So that's a nice resource. Johns Hopkins put up a website with resources on tools for evaluation as well. We're putting on a conference, the first conference in evaluation in digital health technology this summer at UCSF. All stakeholders are welcome, and we've had enthusiastic response. Because funders come to us and say, does this work? Can you tell me if this works? We have an early round in, we're considering a second round. I have no clue whether this actually works or not. So we're going to be answering more of those questions. And then the NIH has a big emphasis on this. So just a quick word about why we think it's important for there to be frontlines innovators. And we think that as you go from idea to impact, which is a phrase we use often, that we really have some unique strengths in this process. You can see there's a whole lot of stuff that we don't have. All the stuff in the Wordle we don't have, we need to partner with, but we have strengths in identifying the pain points. We experience them ourselves, we witness them in our patients. We can conceptualize solutions that fit in well to the process, or where the process needs to be disrupted itself. And then, as we conceptualize the solution and build it out, we can test it. And then, when it's built, we have to swim in our own soup. So we really care whether these are good tools, right tools, etc. We also have to face our patients if we've recommended them to them and they're not working for them. So we have unique strengths in identifying what used to be called therapeutic targets in other fields, and in doing the evaluation all the way across the arc of development. And really, truly, I now teach a lot in different incubators outside of UCSF. I always say, start your evaluation plan the minute you step to the whiteboard with your idea. There are going to be about 15 steps to it. And I'll just talk through that for a second here. The very first step is going to be the focus groups, the interviews. Make sure you know your audience. Spend time there, like Stephen Blank's process and others in the design thinking. We're infusing a lot more of that early and up front. And all the way across, you're going to be looking at different types of pilots and study design to look at engagement, sustained engagement, actual behavioral change. Did the behavioral change cause an outcome in their health? Did that outcome in their health improve the quality of life for that individual? Is it sustained? Did it change the population? The population medicine as well. So there are going to be many steps to this before you get to the very standard post-implementation randomized controlled trial. And this needs to move quickly, and it needs to actually inform your development. As you know, the process of exposure, reiterate, that comes from doing really, really sophisticated evaluation. So just think of those terms. We're going to be defining the field a lot better. We'd love input from anybody who is a stakeholder in this whole process. So we think it's important for the frontlines innovators to be at the table. How do we support that? How do we create fertile soil? You can imagine UCSF is a little bit slow and stodgy compared to the startup world. And when I advise at Rock Health, I often say it feels like I'm in the metabolic rate of a mosquito, and then I go step across the street now. They're not in that opium den downtown anymore. They've moved to this beautiful office. So I step over to UCSF, and it's the metabolic rate of an elephant. And so there's this complete shock to my system each time I do this. But we have to make this oasis of agility within UCSF and within the medical centers and the healthcare delivery system so we can really support our frontlines innovators. They have a critical role to play. They need all of you as partners. It's not like we were doing nothing there. A lot of things have gone out of UCSF, not just in the life science and biosciences and biotech, but actually in digital health innovation. There are quite a few things already that have been in the last 5 years, not just the computational health sciences we've done for years, the genomics analytics, but all the way to consumer-facing apps, including one of the most successful stop smoking apps. So we wanted to figure out what do we do to support digital health innovation. We wanted to have effective healthcare solutions, no question about that. So we started asking all these questions. How can we make it much easier for our innovators to do their work, get the innovation going, study it. Once they show it's effective, here's where things slow down. We don't do a great job of scaling these things up and out of the university for various reasons, mostly because we're missing a whole bunch of that Wordle. But once they've been shown to be effective, which is one of the pieces missing in the big ecosystem, we are obligated to get those things up and out and to more people. And so that's where we are really building a center that's trying to help translate ideas up and out. Because what happens is those projects often die at the end of the grant. And it's quite sad. If you're interested in certain areas and have people done work in certain areas, please talk to us. We're really, really, really interested in partnering. And a lot of work has happened there that hasn't really hit the big showcases and the demo stages. And then we also want to develop innovators, not just things or technologies or solutions, but we want to develop people who will continue to make the solutions going forward. So this is our Center for Digital Health Innovation in a really orthopedically graphic representation. The 4 pillars are innovation, validation, integration, and education. They start in this representation from low touch, so passive virtual resource center, all the way down to high touch to a full incubator portfolio at the bottom of the first column. We leverage existing capacities on campus, including things that you've heard of in some ways, including our internal accelerator Catalyst, our internal tech shop, our contracts and IP offices. And then we've been filling in the gaps. We also have the incubator QB3, many of you have heard of. Then we fill in the gaps where we need them. We're building an online proposal mechanism, much like GUST, so that the throughput isn't limited to our accelerator or our incubators, but many more people can benefit from the 360 review and the what we call the air traffic controller navigating to all the different resources they need. And I'll skip this because I think some of you have heard of Catalyst. We basically take frontlines innovators, put them through an 8-week rigorous process. We have a panel of over 100 outside consultants from many different disciplines, some in the room here today. Many of you know people in our panel. So you can go on the website and look at this. Contact me if this is interesting to you. We take these projects and we help them evolve in a very short amount of time, and then they do a report out. These are projects that have been on campus for several years and risen to a level where they're close to going out the door, but really need some underneath support from the university. And so we can talk about each of these: care web, care collaboration. Imagine as an inpatient, you see all these people buzzing around you, and they're communicating in extremely insecure ways and ways that are never captured in a record. So voicemail, email, text, paging, and sometimes through notes. But now all of this is being consolidated into one platform. A record will be kept of it, it's integrating with Epic, and it's in a secure, HIPAA secure system. Tidepool, I'd love to talk to you about that, Chad. And this was a system built by a couple of endocrinologists initially who were very frustrated because the data in all those glucometers is jailed off. It's proprietary format, the companies own the data. They went to them first to say, can we see your data? Because what you're showing us isn't very meaningful, we can get more meaning out of it. They got no response, so they decided to build an intermediate place where they can pull data in and put it in, it's going to be open source, into a platform, present it to patients in a more meaningful, friendly way, which is an app called Blip, present it to providers in a way they can use the data better. And they can synchronize now the activity, the diet, what was happening stress-wise for that patient, time sync rather than a month later as a history question as they come into clinic. So making some big headways in diabetes there. And Healthy Heart, I'm going to spend little time on this because you can go right on the website, sign yourself up, but it's the Digital Framingham study, and it's now American Heart Association's platform for recruiting people to participate. In a year, we've gotten more enrollees than Framingham got in 10 years because we're leveraging technology such as social media for outreach, clinical data being put in without you coming into clinic, etc. And then the last one is a virtual tumor board that I've been building with a cardiothoracic surgeon colleague of mine for multidisciplinary care in a secure online asynchronous model. So the last two pillars are evaluation, 3 pillars. Evaluation, we've talked about why. We leverage all these systems on campus. We have the highest NIH funding across all of our schools for the first time this year, highest in the country. And then we have fantastic clinical research resources, bioinformatics, the Institute for Computational Health Sciences. If you have a question about wanting to understand more the effectiveness of your technology, please contact us. We'd be happy to either pair you with a domain expert, or we'd be happy to help you figure out the study design and what would it take to get that done. We're the living laboratory, basically. So this also will go through an online proposal system once we get that finished. And integration we talked about, we'll go past this. We're not just integrating the data, we want to integrate the communities as well. We work closely with Rock Health, we support building partnerships from all disciplines. And in the education column, we're using tech-enabled things. We have simulator rooms, we actually have tech-enabled online learning processes and web-based apps we're building. We partner with Rock Health and curriculum. But the bottom one is really important. We put on these events called Meetup of the Minds, where we have us on stage 6 life science and healthcare delivery people defining real problems to you and saying, this is a real problem, would you please help me solve it? And then the startup community and the funding community group up afterwards and create teams and solutions. So we really think there's an important place for Frontlines Innovators, but we need all of this partnering in the middle. So please reach out to us. The website is the Center for Digital Health Innovation, UCSF, or UCSF CDHI. So let's partner to make some things happen and move them from promise to power. Thank you very much.